Good day, everyone, and welcome. I'm Jack Van Horn from the University of Virginia, and I'm very proud to welcome you to this edition of our 2022-2023 Foundations of Biomedical Data Science Seminar Series. This lecture series is supported by UVA's Integrated Translational Health Institute of Virginia, the UVA Brain Institute, the College of Arts and Sciences, the School of Data Science, and through a grant from the National Institutes of General Medical Sciences. Since 2016, the Foundations of Biomedical Data Science Seminar Series has focused on the use of data science methodologies, artificial intelligence, deep learning, and statistical modeling as they pertain to different themes in the biomedical and health sciences. This year's chosen theme is Data Science and the Public Health Consequences of the COVID-19 Pandemic, where we'll enjoy presentations on Fridays from leading thinkers about the issues, the promises, the opportunities, and the hurdles associated with understanding the secondary health effects of COVID-19. These include delayed health checkups, treatments, mental health, drug abuse, increased obesity, and the long lingering health effects associated with long COVID. Participants selected for our Biomedical Data Science Innovation Lab program will leverage these presentations as vital material in our culminating in-person grant development workshop to be held at the Lodge at St. Edward's Park in Seattle, Washington in June of 2023. Today, I'm delighted to welcome our speaker, Dr. Paul Perrin from the School of Data Science at the University of Virginia. Paul Perrin is a professor of data science and psychology here at UVA. He received his Bachelor of Arts degree in English and a BS in psychology from the University of Florida before going there to receive his Master's of Science in Psychology and his PhD in Counseling Psychology with a concentration in industrial and organizational psychology and systems intervention. He trained clinically at the University of Florida Counseling Center and the spinal cord injury and polytrauma units at the Tampa Veterans Affairs Medical Center. He conducted an internship at Baltimore Veterans Affairs Medical Center and the University of Maryland School of Medicine, followed by a postdoctoral fellowship at Virginia Commonwealth University, where he later joined the faculty. Dr. Perrin is a licensed clinical psychologist in Virginia and continues to supervise clinical psychology doctoral students in community settings. And in his research, he uses a combination of data science, modern analytic techniques, and community-based participatory research approaches as key to understanding and identifying the sources of health disparities. This work covers three facets: cultural, familial, and international approaches to disability rehabilitation, social determinants of health, and social justice approaches to understanding and dismantling oppression. In continuing our 2022-2023 Biomedical Data Science Seminar Series theme, Paul's lecture today is entitled Statistical Modeling and COVID-19 Early Pandemic Telehealth Implementation and Mid-Pandemic Post-COVID Neurobehavioral Symptoms. In Paul's presentation today, he's going to showcase a diverse set of data science approaches for modeling important features of the COVID-19 pandemic, including analyses of variance, linear regression, path analysis, and network analysis. He'll present data and results documenting and predicting the rollout of telehealth services at the beginning of the pandemic by psychologists and physicians in the United States. And he'll also discuss data and results concerning the magnitude and patterns of neurobehavioral symptoms in long COVID from across diverse global regions. As always, we are streaming this lecture live and for recording via YouTube. And if you're joining us on YouTube, thank you so much for joining. Also, our specially selected 2022-2023 Biomedical Data Science Innovation Lab participants and alumni are encouraged to submit any questions for Paul via the chat feature in their Zoom sessions. I will synthesize these questions and I'll ask them on your behalf during the last 10 minutes or so of the lecture. And with that, Paul, thank you so much for joining us. We've been really looking forward to hearing what you have to tell us about.
Well, thank you so much for the invitation to present and to everyone for attending this talk today. And thank you, Dr. Van Horn, in particular, for going through my agenda, so I don't need to do it again. But yeah, essentially, this is going to be a two-act performance, if you will. So yeah, I'll be talking about the rollout of telepsychology services in the US at the beginning of the pandemic, and then we'll be presenting some information on neurobehavioral symptom magnitudes and patterns in long COVID. All right, so for that first act, so this is, I'm going to be presenting the results of two different papers from a single data collection. So these papers were published in 2021 in the American Psychologist and also in the Journal of Clinical Psychology. In order to talk about telepsychology, we should probably start by discussing what it is. So, telepsychology is broadly defined as the provision of psychological services via technology. And unfortunately, before the COVID-19 pandemic, very few psychologists were using telepsychology in their clinical practice. So only about 21% of psychologists across the US endorsed that use of telepsychology. There are a number of deterrents and reasons why psychologists didn't want to use it or were unable to use it. They broadly had concerns surrounding practice, so things like having received insufficient training in their doctoral or postdoctoral programs, not knowing how to handle client safety or crisis issues that might come up, maybe insufficient demand by the patient populations that they were working with. And also they had concerns about the efficacy. They were not sure whether telepsychology approaches to clinical work were as effective as in-person modalities. They also reported a number of environmental and policy concerns. So issues of privacy, using the right type of video conferencing technology to ensure patient privacy. They had concerns about legality. For example, if patients cross state lines, then what happens with a provider's license when they're licensed to practice in a particular state? A lot of ethical issues that can come up around confidentiality, reimbursement problems for services by managed care organizations, and also just prohibitive organizational policies and cultures. A lot of providers were working in environments where there were just explicit rules against using telepsychology for their clinical practice. But as everybody's aware, in March of 2020, the WHO declared the COVID-19 pandemic. And as a result, there was just profound shutdowns in schools, businesses, institutions, and a lot of human services transitioned to online models. And one of the biggest changes that we saw had to do with healthcare delivery, where a lot of elective procedures were being postponed and routine patient visits were also being postponed or conducted virtually. But at the beginning of the pandemic, no studies had documented the shifts in psychology clinical practice to telepsychology, despite a lot of widespread kind of firsthand accounts and providers saying that they had made this shift. So as a result, we decided to launch a study right at the beginning of the pandemic. And our purposes of this study were, one, to examine the amount of psychologists' telepsychology use before the COVID pandemic, during the pandemic, and then their anticipated use after the pandemic ends. Second was to examine the demographic, training, policy, and clinical practice predictors of these changes. And the third was to use key elements from respected behavior change models to develop and test a theoretical model of psychologists' adoption of telepsychology use during the COVID-19 pandemic. So for participants to be a part of this study, they had to be licensed to practice as a psychologist in the US, at least 18 years of age or older, and currently practicing, or in other words, seeing patients as a psychologist within the United States. So data were collected from May 11th, 2020 to May 25th, 2020. And as a result, the paper that came out of this, the first paper, was the first paper documenting the rollout of telepsychology services across the US. So it was published July 20th of 2020. So for recruitment, we sent initial and follow-up email invitations to about 27,000 psychologists. So we pulled a bunch of contact information from publicly available email lists, websites, clinic contact information sites. And then we got about 3,600 participants who started the survey. So about 1,000 of these individuals didn't provide informed consent, didn't complete the survey, or they provided kind of nonsensical or impossible responses, or they had lack of a meaningful response to a validity check question. So our final sample was 2,619 licensed, currently practicing psychologists. Sorry, it's stuck. Okay, there we go. All right, here's what these folks look like. So their average age was 57, and their average years in clinical practice was 24 years. So this is actually a pretty well-seasoned sample of psychologists. About 2/3 were women, about 91% identified as white or European American. And these demographics generally mirror the overall demographics of the membership of the American Psychological Association. A lot of these individuals were in individual practice. So 54% reported being in an individual practice in the community, 15% in a group practice, and then largely in other types of medical centers, whether that's VA medical centers, academic medical centers, outpatient treatment facilities, psychiatric hospitals. 46% were in a suburban area, 44% were in an urban area, and about 9% in a rural area. And about 44% of these psychologists were the only ones in their private practice. 33% had about 2 to 5 psychologists in their practice. And then a number, particularly those who were in health systems, had a much larger number of psychologists in their practice. So when we defined telepsychology to these participants, we called it the use of real-time audio, for example, telephone, and or video conferencing technology to provide psychological services. And we asked the psychologists, what percentage of your patient treatment is provided using telepsychology? And so they responded from 0% to 100%. And we asked them to respond with regard to 3 different time points. So one was before the COVID pandemic began in the US on January 20th, 2020, which was when the first documented case occurred in the United States. During the COVID pandemic in the US, so in other words, currently, and then your anticipated perspective for behaviors after the COVID-19 pandemic ends in the US. And here are results. So before the COVID pandemic, about 8% of clinical work was performed via telepsychology. During the pandemic, about 85% was performed via telepsychology. And then psychologists estimated that about 35% of clinical work would be performed via telepsychology after the pandemic ended. We were doing work in the context of telepsychology in this space for a number of years before the COVID pandemic. And a big goal of ours was really to try to increase the adoption of telepsychology. And the research has suggested that it is equally as effective as in-person treatment for literally every type of evidence-based practice that has been tested. And we could not get much movement in the uptake of telepsychology, no matter how many presentations we gave, research articles we published. And so because of this incredible shift, we called this the telepsychology revolution. And it truly was a revolution. There was a 12-fold increase in uptake of telepsychology. And as you might imagine, this was a statistically significant change. Partial eta squared of 0.863. We're not supposed to call things very large size effect, but it was a very large size effect. When we broke this down, about 45% of psychologists reported not using telepsychology at all before the pandemic. And then 85% reported it for using it 10% or less of their clinical work. So very, very little use before the pandemic. During the pandemic, 96% of psychologists reported using it in their practice. 67% reported that they were going completely virtual during the pandemic, and almost 78% reported using telepsychology for 90% or more of their clinical practice. After the pandemic, 89% of psychologists anticipated continuing to use it in their work. So then we broke up using just a series of analyses of variance. What type of psychologists were likely to use telepsychology during these different time periods? So before the COVID pandemic, we had the highest use of telepsychology by those who are working in VA medical centers. So the U.S. Department of Veterans Affairs has been a huge proponent of telepsychology and telehealth, and they've really been a forerunner in the context of the provision of services via telehealth. That was followed by individuals in private practice. So we're seeing people who probably had a lot fewer barriers to practicing telepsychology because they could just make their own decisions as an independent practitioner. Conversely, those who worked in outpatient treatment facilities had the lowest use of telepsychology before the COVID pandemic, followed unfortunately by those in academic medical centers. During the pandemic, the highest use was from those in individual practice. Lowest use was by psychologists in hospital and medical practice. And then the change in telepsychology use is a little bit of a wonky variable to look at, so I won't present it because it has to do with how much they were using it before versus the change. But in terms of projected use afterwards, after doing Bonferroni corrections, we found no differences in the projected use after the COVID pandemic would end. So again, just robustly across the board, we're seeing people who are very, very likely to be using telepsychology. We then conducted a simple linear regression to see what demographic characteristics might predict increased use of telepsychology during the pandemic. So we found a positive, a small size effect of psychologists who had been trained sufficiently in the use of telepsychology. They were more likely to use it during the pandemic. Those who worked in an organizational setting that had supportive telepsychology policies were also more likely to use it. Psychologists who identified as a woman were more likely to use it. And there was a lot of research literature published at the time about women having to play kind of dual roles of working and then also looking after kids and taking sort of a differential burden of childcare responsibilities. So we interpreted this in line with that larger literature. And then there was a very, very small size and barely statistically significant effect of rural locations. So psychologists who were practicing in rural areas were less likely to use telepsychology during the pandemic, which was a bit surprising to us and might be in line with kind of social distancing norms in rural regions that were occurring in the US at the time. Psychologists who treated antisocial personality disorder were less likely to use telepsychology. And we thought that a lot of these folks might be in kind of forensic settings like correctional facilities. Those who perform testing and evaluation were less likely to use telepsychology, as many psychological assessments actually have not been adapted for telepsych administration. Psychologists who treated relationship issues were more likely to use telepsychology. And this is also in line with a lot of research literature suggesting that couples conflicts and domestic violence were increasing during the pandemic. So psychologists who tended to treat these were probably very likely to be able to use those services to provide care. Psychologists focusing in physical medicine and rehabilitation. So this is populations like traumatic brain injury, spinal cord injury, and also a lot of psychologists who are working in medical centers. Those folks were less likely to use telepsychology. And then, so this was just looking kind of at basic demographics. So here we've seen the use of really basic analyses of variance to look at mean differences in use of telepsych, whether that's based on before the pandemic, during the pandemic, or projected after. We also saw this looking at different practice locations. Then we're moving to regression modeling to see how either a different focus of treatment or also different demographic characteristics predict a higher percent use of telepsychology. But we were interested in a little bit more complex modeling beyond what's traditionally used in psychology research. And there's been two predominant models of behavior change in the research literature that we wanted to draw from to see if some of the variables within those models, especially if we used path modeling, might describe some of the uptake of telepsychology. So the theory of reasoned action is a very traditional model of behavior change. It was developed in 1975, and it's been applied to a lot of different topics like health behavior change, like, for example, changing one's diet or engaging in exercises or medication adherence. And it's kind of a basic model, but the idea is that there are subjective norms around particular behaviors, like if you are a part of a social network that's very likely to exercise or eat healthy. Subjective norms affect behavioral intentions to engage in a behavior. And then a person's attitudes about that behavior also are likely to affect their intention to engage in that behavior. So whether they think that the behavior will be effective in its outcome. And then that behavioral intention is theorized to lead to actual behavior change. So within this model, we had attitudes toward telepsychology, subjective norms about the use of telepsychology. So whether psychologists believe that other psychologists were likely to use telepsychology, all of those things channeled directly into intention to use telepsychology, which then transitioned into current use of telepsychology. So the the parameter estimates here are all standardized beta weights. And when a lot of times when researchers conduct a path analysis, they'll start with what's called the saturated model. So they will draw all potential paths within a system of theorized connections. And so that's what we did. So we had an additional path going from attitude toward telepsychology to current use of telepsychology. And you can think of each of these as kind of standardized beta weights within a regression. So each of them is the unique effect controlling for the other effects within the model. So there was no statistical effect of attitude toward telepsychology directly on current use of telepsychology once we controlled for intention to use telepsychology. So that is considered a full mediation. With subjective norms going to intention to use telepsychology and then current use, we still have that additional beta weight of 0.12. And the systems of indirect effects, the two possible indirect effects here, or mediational effects of intention to use telepsychology, were statistically significant. So from subjective norms, because there is still a statistical effect there, we would consider this a partial mediation. Now, the cool thing about path modeling is that you can sort of draw out a theoretical model, and then you can apply fit indices to that theoretical model to see how well the real world data actually map onto your model. And so over here, we have a number of fit indices, NFI, IFI, TLI, and CFI, where 0.90 is or higher is considered adequate, 0.95 or higher is considered a good fitting model. RMSEA, the root mean square error approximation, traditionally 0.08 or lower is considered adequate, 0.05 or lower is considered good. And we have AIC and BIC criterion as well. So here, all of with the theory of reasoned action, all of the fit indices were excellent. They're actually perfect. And so overall, we found pretty good support for the theory of reasoned action in describing psychologists' use of telepsychology in their clinical practice. All right. We then also had the technology acceptance model, which is a specific model applied to use of a new technology. And so it was developed in 1989. And of course, was not really applied to telepsychology until more recent times. And we were the first group of researchers to apply it. So here, a person believes that a new technology is useful or not, over on the left. They also have perceptions about the ease of use of that new technology. Those two variables are theorized then to drive attitudes toward using the new technology, which then drive behavioral intention to use it, and then drive actual system use. So here we did the same thing with perceived usefulness, perceived ease of use, going to attitude toward telepsychology, to intention to use telepsychology, and then current use of telepsychology. And then within the model, perceived usefulness generally exerted a stronger statistical effect on attitude toward telepsychology than perceived ease of use did. And it also exerted an effect directly to intention to use telepsychology. So all of the possible indirect effects or statistical effects, including multiple mediational effects, were statistically significant within this model. So we're seeing sort of good internal support for it based on that system of indirect effects. But then we're also seeing a partial mediation of attitude toward telepsychology on the relationships between perceived usefulness and intention, and then perceived ease of use and intention. And then so this model is explaining 47% of the variance in intention to use telepsychology, and then 33% of the variance in current use. And we also had excellent fit indices here, not quite perfect like we did with the theory of reasoned action, but nonetheless, extremely good fit indices. So we're finding support both for the theory of reasoned action and also for the technology acceptance model for describing why psychologists might or might not be using telepsychology during the pandemic. So the implications of these findings is, we had excellent fit of both these models. And so the models suggest pretty ripe targets for increasing psychologists' provision of telepsychology, both during the COVID pandemic, but also beyond. So there are a number of changes that the Centers for Medicare and Medicaid implemented in terms of reimbursement of telepsychology at the same rate as in-person visits. And so what we're arguing is that, some of those policies are extremely likely to continue to increase psychologists' perceptions of the usefulness and improve their attitudes toward the use of telepsychology. So we highly recommend that governmental agencies enforce comparable reimbursement structures for telepsychology versus in-person visits. And again, all of the literature suggests that they're equally effective. And so why not reimburse them at the same rates, particularly to support the continued rollout of telepsychology services. We also recommend that legislation, particularly that involving HIPAA, with regard to practice across state lines and licensure provision for services across state lines, continuing to support those changes would ameliorate concerns related to legality and confidentiality that psychologists have that have been found over and over in the previous literature as one of the major barriers. And again, if we remove that barrier, then we're theorizing that a lot of the variables in the theory of reason action and technology acceptance model then are going to increase in the positive direction, which then set off that theoretical cascade of effects. All right, end of Act 1. We can transition now to Act 2, focusing on neurobehavioral symptoms and long COVID. So the findings from this for this part of the talk are going to be from a single study also, although a separate study from the first one that I mentioned. And this is part of 2 papers that were recently published in 2022 in the International Journal of Environmental Research and Public Health. All right, so you might have heard of the term long COVID. It's also been called persistent post-COVID syndrome. And it's a set of symptoms that appear after infection by the SARS-CoV-2 virus and that persist for 4 weeks or more after the infection. Some researchers have given it sort of a 8-week or longer time window, although 4 weeks or later is fairly common in the research literature as well. Now, long COVID is more common in individuals with severe COVID-19 presentations, but it also can appear in people who had mild infections. And so some of the symptoms are ones that you might be familiar with. These are things like fatigue, general bodily pain, headaches, breathing difficulties, anxiety, and depression. But there also are a lot of long COVID neurological symptoms, including headaches, dizziness, loss of smell, loss of taste. Also, more serious neurological conditions like prolonged loss of consciousness, stroke, encephalopathy, meningitis, seizures, and demyelinating diseases. There are 3 overarching theories about why long COVID neurological symptoms exist. And so the idea is that the virus attacks the brain, and these theories do have some scientific support to them. So the first is with direct virus infection to the astrocytes. So astrocytes are these sort of star-like structures within the central nervous system that are thought to regulate cerebral blood flow, among other functions. Second is overreaction of the immune system, which has been termed cytokine storm. And then also blockage of blood flow in the brain causing hypoxia or a lack of oxygen. So when we conducted this study, the literature was really lacking in long COVID studies, and particularly those with large sample sizes, those from diverse global regions, and also those using validated instruments. So a lot of researchers were kind of creating their own yes/no checklist of symptoms that may or may not actually have been validated psychometrically. So the purposes of this study were to compare the presence of somatic, cognitive, and emotional neurobehavioral symptoms in a large international sample of individuals, as recalled before their COVID-19 diagnosis, during their COVID-19 infection, and currently, or in other words, at the time of their survey. And then we wanted to examine risk factors for increased long COVID neurobehavioral symptoms. And then finally, we wanted to apply a network analysis to investigate the patterns of somatic, cognitive, and emotional neurobehavioral symptoms in the subsample of Spanish-speaking individuals with a history of COVID-19 positivity. And we wanted to compare that to a separate non-COVID control sample. So we recruited 1,001 adults from 32 countries who had previously tested positive for COVID-19 via a viral or antigen test. And 650 of these individuals were Spanish speakers from 26 countries, And they averaged 175 days since their diagnosis or since testing positive for COVID-19. So the data were collected in March to June 2021, so fairly early in the pandemic. And this is right when vaccinations were beginning to be rolled out in developed countries, and particularly for high-risk populations. So it's important to say as a caveat, the vast majority of people who participated in this study had not been vaccinated for COVID. We also had 443 COVID-19 negative Spanish speakers from 19 countries. So we knew that these folks were COVID negative because we had collected data on them before the COVID-19 pandemic. So participants were recruited through professional mailing lists and collaborators' contact networks. So we used Facebook groups, we paid for advertisements on Facebook. And then also we were collaborating with one center that had a COVID-19 patient database. This was Mount Sinai in New York. The participants completed an online version of the Neurobehavioral Symptom Inventory. So it's a 22-item self-report measure of symptom severity across cognitive, affective, and somatic domains. And it's generally been applied for neurological conditions like mild traumatic brain injury. So participants reported each symptom at 3 time points. So before COVID, during their COVID-19 infection, and then now when they were completing the survey. So here are the results. So this is the subscale score for somatic symptoms. So you can see over on the left, participants' pre-COVID-19 scores, which as you would hypothesize, just shot up dramatically during the COVID-19 infection. And then you also saw some improvement. So here, these indices are Cohen's d, where 0.2 is considered a small size effect, 0.5 a medium size effect, and 0.8 a large size effect. So we see a medium size improvement in somatic symptoms from during the time of the COVID infection to now. But the thing that was fairly disturbing to me is that there was an almost large size effect, a Cohen's d of 0.76 from before COVID to now in terms of the increase in somatic symptoms. So on average, 175 days later, we're still seeing an almost large size increase in reports of somatic symptoms. And then when we broke apart that subscale, we found that the biggest remaining symptoms were still from participants' report of their sense of smell, bodily numbness, and dizziness. Then looking at affective symptoms, we saw that same huge jump, and then a small size improvement in affective symptoms, but a large size increase in those affective or emotional symptoms from before COVID to now. So we're seeing tremendous continued mental health problems in individuals who had a history of COVID-19 infection. And then within that subscale, the largest continued problems were pre-COVID fatigue and sleep problems. Then for cognitive symptoms, again, we saw that huge increase from before COVID to during COVID. And then we actually did not find a statistically significant improvement in cognitive symptoms 175 days later on average. So that Cohen's d did not even reach a small size improvement. Conversely, there was a large size increase in cognitive symptoms from before the COVID pandemic that remained 175 days later on average. Within the subscale, the largest continued problems were reports of concentration problems and then reports of forgetfulness. We then ran some regression models for the somatic, cognitive, and affective domains. In step 1, this was a hierarchical regression, so we had a number of demographic variables. And then in step 2, we added in a number of other kind of COVID-specific variables. And then so here I'll just be presenting the results from step 2. So we found that people who identified as male, so men, reported lower levels of somatic, cognitive, and affective symptoms. We found that individuals with another chronic health condition other than COVID reported higher levels of somatic, cognitive, and affective symptoms. We found that individuals who had received oxygen therapy reported lower cognitive symptoms. So again, these data are correlational, but you could infer that oxygen therapy helped moderate the development of COVID symptoms. Individuals who reported higher COVID-19 severity during the time of infection reported higher somatic, cognitive, and affective symptoms. And then unfortunately, days since diagnosis was associated with symptomology, but in a positive direction. So greater number of days since diagnosis, we're seeing higher levels of somatic, cognitive, and affective symptomology when we're considering this cross-sectionally in the context of the overall regression model. And that is, of course, controlling for all of these other variables. We decided to look differentially by global region. I will say that interpret these data with caution because it's hard to know whether a snowball sampling approach in these different countries is what accounted for some of these differences, where, one person might have shared it to their network and then that network is more homogeneous in a particular global region. But nonetheless, we did find overall that individuals from North America and Europe and Central Asia reported higher levels of somatic symptom severity relative to those in Latin America and the Caribbean and relative to those in Sub-Saharan Africa. We found that same effect for affective symptom severity, higher rates in Europe and Central Asia and North America. And then we found the same effect for cognitive symptom severity. Again, highest in North America, followed by Europe and Central Asia, and then Sub-Saharan Africa and Latin America. So again, you're seeing kind of traditional psychology, behavioral science approaches with ANOVAs and regression modeling. So we were interested in applying more modern data science approaches to our data. So we decided to apply a social network analysis to the 650 Spanish speakers with long COVID, and then a separate sample of 443 individuals without a COVID-19 history. So the purpose of social network analysis is to model, among other things, clusters of related symptoms as a dynamic system. So in order to conduct this analysis, we use the estimate network function from the bootnet package in R. We use the Epic Glasso routine to estimate a network of partial polychoric correlations, which you can think of as partial correlations or a relationship among variables controlling for all other relationships in the network. We use regularization, which is a machine learning algorithm that repeatedly reduces the smallest edges in the network to zero and then iteratively re-examines model fit. And we compared the two networks. So the 650 individuals with a history of long COVID or a history of COVID and the 443 individuals without the COVID history. We compared those two networks statistically using a 500 iteration permutation test from the network comparison test package in R. All right, so graphically, here are the two networks. So over on the left, we have the long COVID network. Over on the right, we have the control network. So yellow nodes or yellow symptoms are the somatosensory symptoms. The blue symptoms are the cognitive symptoms, and then the green ones are the affective symptoms. So over on the right is the long COVID network. What we can immediately see is that by comparison, the control network is largely disjointed relative to the long COVID network. So the somatosensory symptoms kind of form their own symptom cluster and don't actually bridge to any of the other symptoms. So it's kind of a diffuse just pattern of symptoms in individuals without a history of COVID. And then in those with long COVID, we're seeing actually kind of a organized, interconnected set of neurobehavioral symptoms. Then when you look within the models, one of the biggest differences that we found was the relationship between the organize and headache nodes. So in the long COVID group, we find a pretty big connection between those two. So the thicker the line, the stronger the connection among those variables or those nodes. And then we find a very little connection between the organized and headache nodes in the control net. So does that mean that headaches are causing people to have organizational problems? Or does it mean that there might be some organic brain damage in the context of long COVID that's creating headache pain and then also creating organizational issues? It's hard to know. These data are all correlational, but nonetheless, we're seeing that those two symptoms in particular are highly related to each other, particularly relative to the control group. So if we're going to draw some conclusions, we have to think about a few limitations. So, again, we used an online snowball sampling approach. And so there's definitely some non-representativeness of these samples. We're not in any way saying that this represents, an entire global population. Clearly there are a lot of global regions that were not well represented, like in Asia. Also, the study was administered either in English or Spanish. And as a result, everybody had to speak those two languages. So there's profound limitations in how far the data collection can actually spread just based on linguistic limitations. Then, participants also might have recall bias when they're comparing their current symptoms to those either during or before an active COVID infection. So I would argue that very likely the reporting of telepsychology use by psychologists was going to be a lot more accurate because it's a very kind of concrete behavioral anchor, where when you're thinking about COVID symptoms, people who have more mental health issues or are more distressed might retroactively view symptoms that they had before the pandemic as being kind of higher in magnitude, or and so as a result, there is some response bias that you have to take into account. But nonetheless, we're very consistently finding that individuals with that history of COVID are reporting continued symptoms and much higher symptoms than they had before the pandemic. In terms of implications, it's just, we're finding that just incredible, consistency across, all three domains of reporting these substantial continued symptoms. And so, we're also seeing evidence that long COVID is a coherent, identifiable pattern of neurobehavioral impairments. Now, you might find this a little bit depressing because you say, oh my gosh, they're based on, COVID rates, so many people are probably experiencing these issues. And it is true, there are a lot of neurobehavioral impairments out there that people are experiencing. And there are, neuropsychological tests that are showing evidence of that as well. But what I will say is that there are emerging cognitive rehabilitation approaches that have been found to be extremely effective at treating long-term neurobehavioral symptoms. So I have colleagues at University of Alabama, Birmingham, who have found great evidence already for some of their cognitive rehabilitation approaches. So you can think of these as like almost, stereotypically like brain training games where they do different types of cognitive exercises that help people kind of adjust and regain function from neurological conditions. So this has been applied to traumatic brain injury, stroke, and now we're finding evidence that it applies pretty well to long COVID. And so we're just arguing that those type of rehabilitation services, and particularly cognitive rehab, are critical for individuals reporting elevated long COVID symptoms. Now, if I were to take kind of a step back, and obviously this is a data science colloquium series. And so, here we've showed that a diverse set of data science approaches for modeling important features of the COVID-19 pandemic can include really a heterogeneous set of analyses. So things like analyses of variance, linear regressions, path analyses, and network analyses. And I would argue that each of these approaches can answer, very different research questions, even using the same data set. So, a lot of times researchers will start off with just describing means and standard deviations and looking at differences among groups on some variable of interest. And then maybe they, work their way up a little bit further to, regression models where they might think of certain predictors and try to, fit the best regression model that they can to, predicting some outcome. But even still, I would argue that the field still needs to, take those approaches and move forward. So, have theoretical models that you can test using path analyses, or even more kind of bottom up exploratory approaches like network analysis that don't necessarily presuppose a prior existing theory, but nonetheless can be very complementary because they're data driven, they're inductive rather than deductive. So, it's really this combination of traditional and more modern data science approaches that can be extremely synergistic to paint the most comprehensive and nuanced pictures of patterns in data. All right, that's the end of my talk. This is my email address. If you have any questions, feel free to get in touch with me, and I'm happy to take any other live questions that you might have.
Paul, thank you so much. I know that there was a question that you might have touched on and given a satisfactory answer but I wanted to kind of cycle back to it. Is that in the first portion of your talk where you were talking about, like, pre-COVID, there were barriers to the telepsychology usage by practitioners. Do you feel that that was due to just resistance by the psychology community towards the efficacy of it? Do you think it was a technological barrier that people just didn't want to change, but COVID sort of forced it upon us? Or do you think that it was a consequence of the perception that the patients or the recipients of that telepsychology wouldn't get as a quality experience from it? Did you have a sense of that from your data?
Yeah, pre-COVID, we did collect a lot of data, from psychologists on their perceptions about kind of barriers and facilitators of telepsychology use. And so you have a lot of what I call kind of like, intrapsychic barriers. So these are ones that the psychologist perceives. So this can be things like, the bias against, telepsychology being effective. I mean, I think that's probably a huge one. I've heard a lot of providers, especially before the pandemic, say, well, telepsychology just is not as effective as when I'm meeting face to face with a client or a patient. And to be honest with you, the evidence for that statement is not there. In fact, the vast majority, if not all, research that I've uncovered has suggested that telepsychology approaches are just as effective as in-person approaches. Now, there are some limitations to that. If you think about like a neuropsychological assessment or other forms of assessments that require some sort of like behavioral criterion or response from the patient, it is true that those are more difficult to administer and to evaluate. You think of like IQ tests, for example, are a little bit more difficult to do over telepsychology. But yeah, the vast majority of research has suggested that there's no difference. The only difference that has emerged is there's been some research suggesting that the relationship quality is a little bit better, although a very, very small sized effect better for in-person versus over telepsychology. And then, yeah, I think a big issue too is people just were never trained. I mean, believe it or not,
Yeah.
how many times would we have Zoom meetings before the pandemic existed? Like, right, almost never. And so, people were using Skype or, other approaches where they would talk to friends and family, but not necessarily in a professional setting all that often. So people just were not familiar with it. And then, there also were a lot of, I think in defense of psychologists, there are patient issues that come up. So you see issues of bandwidth where, particularly in rural areas or, if people are on kind of data limited plans, it can be very difficult for them to access telepsychology well. And so, I've done randomized clinical trials looking at the rollout of, telepsychology interventions, for example, for, caregivers of older adults. And I would say that about a third of the caregivers we work with are just simply not able to connect over a smartphone or over a computer. And we have to go through just straight up, a telephone. So, there are those kind of practical barriers. But I think a big thing too is just not the intrapsychic, but the environmental barriers of the managed payer environments. If psychologists cannot get reimbursed for services at the same level that they can in-person services, despite there being no evidence that there should be a difference, then yeah, they're going to want to do in-person work just to simply make more money, and that makes sense, right? If they're running a business. And then also there are all these, kind of odd ethical issues that come up across practicing across state lines. And is it where the psychologist is? Like that's where their license is. Like if you go on a vacation out of state, then can you no longer practice, or is it where the patient is? So, I think there are some sort of structural and policy barriers that create a lot of that resistance as well.
Thank you, Paul. There were in your the study that you described where you're looking at the various factors that contributed to pre, during, and post COVID. I was struck by some of the other chronic conditions that you kind of categorized, but that ended up being a particularly strong effect. And I'm just kind of wondering if you could comment more on the role that possibly COVID or the experience of COVID may have had on those pre-COVID comorbidities. Did it like cause them to become worse? Was it just kind of compounded and piled on top of them? Would they have just experienced, more symptomatology, more symptomatology anyway? Do you have any insights there?
Yeah, well, in some of those regression models, the presence of the additional symptom was controlling, I'm sorry, the additional health condition was controlling for all other variables in the model, including, severity of COVID-19. So what we were seeing is that there's an added burden on neurobehavioral symptoms of having that additional chronic health condition. But there has been some research looking at kind of interactions where, particularly people who have cardiovascular issues, how that compounded with a COVID-19 infection in terms of producing disparate outcomes like additional hospitalizations, more neurobehavioral complications. So yeah, that's absolutely been a big one. Yes, we published a study recently looking at COVID-19 vaccination uptake in individuals with chronic health conditions, exactly because that's such an important topic of seeing folks who have those additional conditions as being really important for encouraging higher levels of vaccination rates to ward off some of these symptoms that we're seeing here that they're at additional risk for.
In your social network kind of analysis that you performed, where you showed that you had certain bridges between certainly some of the somatosensory symptomatology and some of the mental health symptomatology. Yeah, thank you for bringing that graph up. You have the various what you call bridges there. And I'm wondering, you sort of touched on it about causal mechanisms here. And I'm wondering if you have any further comment on those or any other insights that people could take away is that when they're performing analyses like this, what they need to be aware of in terms of making causal inference.
Yeah, causal inferences are super tricky, particularly when you have cross-sectional data. So even though we have this kind of faux longitudinal data of looking at these variables, asking people before, during, and after the pandemic, the methodology itself of collecting the data cross-sectionally prevent additional causal inferences that you might be able to engage in if you're looking at longitudinal data. So, whenever possible, if you can conduct these studies longitudinally, do multiple waves of data collections, then you can use cross-lag panel techniques to help infer relative causality among pairs of variables, controlling for other variables within the model. Here, yeah, I mean, at the end of the day, this is really a cross-sectional model. And yes, we're controlling for every other symptom in the network, but nonetheless, it's cross-sectional. So we can't say that one of these symptoms, one of the bridges is due to one node or one symptom versus another. You can, of course, rule out any sort of third variables by controlling for other things, like if we wanted to control for age or control for presence of another chronic health condition, to say that that's not causing these relationships. But nonetheless, it's very difficult to say that headaches cause organizational problems or organizational problems cause headaches, because the basic structure of the study itself is not causal. So, in psychology, we have, an experiment, which is differed from other forms of studies like correlational or cross-sectional studies, because the methodology itself controls for every other possible variable, wherein it's only an experimental manipulation that can cause a change in a dependent variable. But it is much more difficult to do this cross-sectionally, although there are folks who try to do it by just controlling essentially for everything you can, and then seeing what's left.
And one of your take-home messages I thought was really important is the notion of taking a data-driven approach. You can apply some of the methodologies that you've described here. You can apply AI and machine learning technologies, et cetera, that are very popular right now. But it's really important to have a theory of some kind that is testable and can be validated and can be examined, that helps to explain the patterns and the data that you're seeing. So much of our I don't know, so much of the stuff what we're seeing these days are, we just threw every machine learning algorithm at the data and we just found the one that classified, again, the best percentage classifier. And there's no reason other than the math worked out in our favor. And that seems so theory free that it is probably worrying, especially in cases where you're looking at clinical kind of predictors. Do you have any further comment on that?
Yeah, I mean, that within the discipline of psychology, there's the famous quote, there's nothing so practical as a good theory. And, I think that psychology tends to be pretty good at having a theory for how variables relate to each other, what might be causal, what kind of, cascade of events might occur. And, we also have, decent methods that have been well accepted in the field, like path analyses, structural equation models, where we specify the theory ahead of time, and then we collect data to support the hypotheses that then support that theory. But yeah, in the context of machine learning approaches, when I've had conversations with a number of my colleagues in psychology about this, because this is a huge area for me, is trying to bring more machine learning, more data science approaches back to the discipline that I've been trained in. I do get that resistance. They say, well, we're concerned about the replicability of these models because, to some extent, they're based on a single sample, even if it's a large sample. Nonetheless, sometimes these machine learning algorithms are so good that they're capturing variance that's there, but it's actually just chance variance relative to that specific sample, right? So, can we also bring some theory to the variables that we're choosing and specifying as being the most important in the context of these models? Can we sort of start with that theory and use both approaches, right? I mean, there's something about deductive reasoning and deductive science, and also about inductive or more kind of data-driven, empirically based science, where the data are telling you the story versus you telling the data the story and then asking if that's really the story. So I think you have to approach it from really both methods.
I think that's a very important point. And thank you, Paul, for sharing your work with us and having a little chat with us. We know you have a busy day ahead, so we'll let you go. But thank you so much, Paul. This was really great. And thank you, everyone, for joining us. And everyone have a wonderful weekend, and we'll see you again next week. Thank you.
Thank you for the invitation.